Hi, everyone. Thanks for joining the School-Based Health Alliance for our webinar, Addressing Adolescent Relationship Abuse in School-Based Healthcare, presented by Lisa James, Dr. Liz Miller, and Meg Kane. The presenters will provide a brief overview of adolescent relationship abuse and discuss considerations for implementing a protocol to address adolescent relationship abuse in the clinical setting, incorporating learnings from their practical experience. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, and behavioral health issues get quick expert attention. And we all know that healthy students make better learners. Now we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We will address questions following the presentation. If you would like to add your comments through the chat function, please select all panelists and attendees before sending the message so everyone can see it. We will also have closed captioning for this webinar. To turn it on, click on the CC or closed captioning button on the Zoom control bar. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance website for additional archived webinars for topics such as the ones you are viewing on your screen. This webinar is the first in our 3-part IPV series. We invite you to join us for the next webinar, which will focus on digital dating abuse. We will share the registration link for that session in the chat. It can also be found on our website. As we mentioned, this webinar is part of a 3-part series on adolescent relationship abuse. The series is part of a larger body of work funded by the Bureau of Primary Health Care, BIPIC. Through BIPIC, the School-Based Health Alliance has a national training and technical assistant partnership to support health centers in serving school-age children. Before I introduce today's presenters, I would like to review the objectives for this session. After today's webinar, participants will be able to explain the dynamics of adolescent relationship abuse, or ARA, identify 3 reasons why school-based health center providers might consider discussing ARA with their patients, and describe the CUES approach to discussing ARA with patients. Now I would like to introduce our presenters for today. Lisa James is Director of Health at Futures Without Violence, a national health and social justice organization that has been working for over 30 years to end violence against women and children in the US and around the world. Lisa has been working for 25 years to lead the organization's national health initiative on violence, partnering with healthcare providers and domestic violence advocates across the country to improve the health and safety of survivors and promote prevention. Dr. Liz Miller is Director of Adolescent and Young Adult Medicine and Medical Director of Community and Population Health at UPMC Children's Hospital of Pittsburgh. She's also a member of the newly established Pennsylvania School-Based Health Alliance. She has over 2 decades of experience developing and testing clinical and community-based prevention programs to address interpersonal violence. And Meg Kane is a pediatric nurse practitioner and pediatric sexual assault forensic examiner at Nationwide Children's Hospital in Columbus, Ohio. She works in the hospital's school-based health centers, as well as serving as the clinical outcomes coordinator, using quality improvement principles to advance departmental and institutional aims with a specific focus and interest in health equity and social justice. Now I'll hand it over to Lisa and Dr. Miller.
Thank you. We can go to the next slide. Thank you so much for joining us. My name is Lisa. It's just a great pleasure and honor to join you today. I want to take a moment before we start to thank you for everything that you do every day, but particularly this year during the pandemic. I know what a rough year it has been, and I know how hard health professionals in general and school-based health professionals specifically have been working to reach kids in need of support and to promote education and safety. So I just want to start there and applaud you for all of your good work, and thank you so much for that as we move forward into what can be a challenging conversation around adolescent relationship abuse. But I hope that you'll come away with some strategies that will help you think about this and promote prevention in a new way. Next slide, please. Like the School-Based Health Alliance, Futures Without Violence also runs a national network, a technical assistance center for community health centers, the National Health Network on Intimate Partner Violence, Human Trafficking, and Exploitation. And what that means for you is just that we have a lot of resources, tools, and technical assistance offerings that if you want to go deeper on any of these issues, want additional training, or just want to reach out and talk to us about some of your approaches as they relate to prevention and response to adolescent relationship abuse, we have a number of tools and resources available to you. And so you'll see a lot of links there on the slide, and please do reach out if you have any further questions. Next slide, please. Just in terms of level setting, there's a lot of terminology that's often used around domestic violence, sexual violence, teen dating violence, all trying to capture the different ways in which people might use harm in a relationship. For the purposes of this webinar, we're going to be using the term adolescent relationship abuse primarily, unless we're referring to a specific study. And each term has its own strengths and weaknesses, but this is the one we'll be using moving forward today. And then thinking about the dynamics and understanding adolescent relationship abuse and what an unhealthy relationship really looks like, it's looking at a relationship where one person uses a pattern of methods or tactics to control or coerce their partner. And so it's the pattern that's an important piece here of the story. It's not a one-time event, but it's really an ongoing pattern that's not just about physical violence, but a lot of emotional abuse and other coercive behaviors that one person uses over their dating partner. Particularly during the pandemic, we've seen some unique ways in which coercive partners are using even something like shelter in place rules to try and control the ways in which their partners are connecting with their friends or family members. So just an example in terms of the lengths that coercive or abusive partners might go to in order to, again, maintain that power and control. Next slide, please. Unfortunately, we're seeing very, very high rates of adolescent relationship abuse. 1 in 5 U.S. teen girls reporting either physical or sexual violence in their lifetime in an intimate relationship. Next slide. And also, when you're thinking a little bit about sexual violence specifically, 1 in 8 female and 1 in 26 male high school students report having experienced sexual dating violence within the last year. I want to lift up that sexual minority groups are disproportionately impacted by violence, and some racial and ethnic minority groups are disproportionately impacted by different types of violence. And also just want to recognize that the research historically has been using gender binary frameworks. And so as we move forward, we're trying to have emerging work that includes a whole range of gender identities, but you might see that in the research moving forward. So we're seeing really high rates among the young people in which we're serving. And when you think about sexual harassment more broadly, as many as 48% of high school and middle school students report having experienced sexual harassment. So this is a problem that's definitely impacting the young people that you are working with and serving through your work. Next slide. Again, in thinking about those dynamics and trying to understand who's using violence and abusive and coercive behaviors in their relationships, We see with adolescent relationship abuse that violence is still gendered, but young people of all genders do experience and perpetrate. So what we're seeing is that girls are more likely to be victims of physical and sexual abuse, and boys are more likely to be victims of psychological abuse. And in some cases, the mutual aggression is common. So I share that with you to just understand, and as you're working with young people, to kind of consider the context and the impact of the abuse and its outcomes when you're working to promote both prevention and a response to someone who's been exposed. Next slide. I'm happy to see that you'll be doing a whole session around technology, because it's particularly with young people. 1 in 4 teens in a relationship report having been called names or harassed or put down by their partner via text or cell phone. And you see the stats here. They're just technology-based harassment is a real red flag for other types of abuse. And so it's important to be comfortable talking about that with the young people in which you serve. Slide, please. And thinking about health, it's not just about promoting the safety of the young people that we're working with, but it's also about reaching those health promotion goals that you all share. And unfortunately, I think when we started this work so many decades ago, mostly people were thinking about injuries as the major impact of adolescent relationship abuse or any kind of intimate or sexual violence. But you see here, this is just a wordle of all the types of long-term and chronic health consequences of abuse that can last for many, many years. And it really makes it very clear why it's critical for healthcare providers and public health professionals to be part of the solution, because they're really seeing strong connections between violence and this whole host of health consequences. I'll just lift up teen pregnancy or unintended teen pregnancy because many of our programs are looking at that, and just note that adolescent girls in abusive relationships are nearly twice as likely to become pregnant than non-abused girls. So again, not only do we want to promote health and safety of our young people, but we also have an opportunity to prevent unintended teen pregnancy and a whole host of other negative health consequences. Next slide. And that's why we feel passionate about having health programs in general and school-based health specifically as an essential place for prevention and for identifying and responding to those who have been exposed to adolescent relationship abuse. We know from the data that you're seeing very high rates in your health centers of young people who've been exposed to violence. And we know that school-based health interventions can make a difference, both in terms of decreasing violence and also creating a safe space for young people to come to talk about prevention and healthy and unhealthy relationships. And I know Dr. Miller will be talking about that a little bit later on today. So with that, I'm going to turn it over to Megan. You've been doing such amazing work in your setting. So to give it a little bit of detail around what this might look like.
Thank you so much, Lisa. I actually could just listen and talk to you for quite a while longer. That was so comprehensive and wonderful. Briefly, I do have to make a disclosure. I have to disclose my pharma relationship. My son was in the Pfizer vaccine trial, and now I have to disclose this every time I give any sort of talk. I have no actual pharma money, but if you are offering any, just hit me up. Next slide. My name is Meg Kane. I'm a nurse practitioner at Nationwide Children's Hospital, specifically in the Care Connections clinics, which are our school-based healthcare centers. Just briefly, oh, thank you so much. Briefly, I'm going to share that our program was initiated in 2015. We started off in 2 schools in 1 urban district, and now in 2021, we are in 14 schools in 2 districts. We have 2 mobile units that we use to leverage access to care in areas where we don't have existing kind of permanent standing clinics. I don't have to tell this audience all the advantages of school-based health centers, but I will say, as most on this call already know, school-based health centers can decrease truancy, improve graduation rates, decrease missed class time, decrease unintended pregnancy rates, especially for marginalized youth, all by providing confidential and easy to access care in a setting that is familiar and safe for our young people. Our goal as a program is to exist to improve outcomes by removing non-academic barriers to learning, which we do by encouraging our patients to access care with their grown-ups or independently. And I will also say that this continuity of care and wraparound services, which are inherent to school health, are just two of the reasons that I think school-based health centers are so uniquely positioned to specifically and effectively address intimate partner violence and other social determinants of health that are so key in ensuring long-term wellness and best outcomes in our young people. We can go to the next slide. Thank you. We're going to talk a little bit today about Molly. This is not Molly's real picture, and Molly is not her real name, but this is a patient of mine that I'm going to share about that was the genesis for my involvement in this arena. Molly was a very funny, engaging, outgoing 15-year-old girl who was on the cheerleading team and the drill team, and she made great grades, and she was very popular. And she came into my clinic one day because she needed a well check and she needed her sports physical paperwork signed. I started with my normal process. We did a history and kind of a normal history taking, including a safety screen, a social history. She denied any concerns. As I started the physical exam, I noticed that she had very faint bruising on her bilateral forearms and her neck. And I asked her about it, and she was pretty casual about it. She said that recently her boyfriend had gotten angry with her and he'd become violent and physically abusive. But she said this happened with him sometimes. It's just something he did. He always apologized. And she didn't like that part of him, but overall he was a really good boyfriend, and their parents both liked each other and were supportive of the relationship. So she really didn't have any plans on ending the relationship. She did not find the behavior maladaptive or abnormal in any way. I was able to connect Molly with resources that day, but I was left to confront the reality that my current safety screen was not doing its job, and therefore I was personally providing subpar care. I was doing a bad job. So if Molly had not had visible bruising, or if she had come in even one day later, I would not have caught that. I would have completely missed it. I would not have figured out that she was a survivor of intimate partner violence. And I started wondering how many other kids had I left in a dangerous situation because I'd not asked the right questions, or I'd relied on a system that was not serving my population very well. And what was I going to do about this? Next slide, please. So this was kind of the back of the envelope roadmap I'd sketched for myself when I was reviewing the literature on the subject of intimate partner violence in adolescents, some of which was composed by Dr. Miller, who's on this call, and how I was going to address intimate partner violence in our setting. Though I want to be super clear, I'm giving myself a lot of credit here, because if we take a step back, we can realize that this blueprint has already been laid out for us in pediatric medicine in a lot of ways, right, friends? Like, if we look at the other ways we've sought to change culture and habits in pediatric medicine, let's think about things like vaccination rates or safe sleep conversations. We can kind of understand that we have a very clear pathway. We don't just engage in one-off efforts and then consider the problem solved. We know that what is helpful and constructive with our patients and their families are these multi-tiered approaches that will lead to change conversations and then subsequently change culture and then initiatives, and then ultimately moving the needle towards safer environments and healthier habits and behaviors for kids. So when I was looking at this, I thought, okay, I need to understand the problem. Am I doing preventable harm? Yeah, big time. Then, okay, the next step is changing behaviors, and then ultimately change the culture of the setting. And that's going to be the most successful approach to improving care. So we can go to the next slide. So a little bit of background here. Nationwide Children's Hospital is committed ultimately to the safety and care of its patients. And we're actually national leaders in improving patient safety, and we are the first children's hospital to describe and publicly aspire to a goal of zero preventable harm. Here's why that matters. If we understand that youth violence is occurring in relationships, as Lisa so beautifully explained just now, so we do understand that. And if, as we just saw with my own example, we understand that our current practice for screening for safety is suboptimal, which it is, to put it lightly, then we understand that I as a provider cannot say that I am achieving zero preventable harm. but because I'm using inopportune instruments and reaction-based violence counseling, and I'm letting kids stay in dangerous situations without addressing it. So I'm contributing to this preventable harm situation. And that's not consistent with our values as an institution or my goals as a healthcare provider, nor my morals as a person. And more broadly, for all of us, addressing violence in youth in the primary care setting speaks to several of the IOM's 6 domains of healthcare quality, specifically the provision of care that is safe, effective, and patient-centered. So it's really very consistent with what we need to do. So next slide, please. So what we have here is, all of these adult medicine and public health organizations who are recommending intimate partner violence screening and counseling. In our hospital, we weren't really consistently doing this outside of our teen and pregnant clinic because that's a recommendation for pregnant women. What I want to focus on is universal assessment being considered the gold standard per the Ohio Domestic Violence Protocol for healthcare providers. But let's dial in even further on that word universal. When I hear the word universal, it kind of makes me think of, looking at all people in all settings, right? Again, going back to that multi-tiered approach. So talking to kids about their relationships in as many different environments as possible. And what I would say then is that's another way that school-based health centers are uniquely positioned to make a pretty important and powerful impact. We already are talking to kids about so many different things in an environment where they feel safe and secure. And I think if you can even then take that a step further and leverage your relationship with your partner school and say, can we also do this kind of counseling or this kind of assessment in the school environment, talk to kids about healthy relationships, healthy boundaries, there's not really a disadvantage there. It's a wonderful way to strengthen your message. And I think, the more ways that you can provide kids that referential point of view, the stronger your message is going to be, and the more chance that they're going to have to kind of understand and realize that this is a safe space, and this is a way that they can, address this with you and with their peers. Next slide, please. Okay, this is the exciting part. So a little bit about quality improvement. QI is the framework we use to systematically improve the care we deliver to patients. It's stepwise and measurable processes to help collect data and analyze change. The best way that I've heard QI explained, and it's what I use now as well, is to think really, really big and start really, really small. And when you're thinking about topics and you're thinking about what processes you're going to change, think about the things that you can talk about ad nauseum, right? So I just put this as an example. Why do so many people order respiratory infection array panels in the outpatient setting? I don't know. Why do they keep doing it? I have no idea, but they keep doing it anyway. For me, this area of hyper-focused nonstop talking was twofold. One was how poorly we are addressing teen dating violence in the primary care setting, which was pretty poor. And the second was how I personally had failed my patient population by relaxing into and relying on the status quo. And fortunately for me, it was here where I could kind of implement the tools and skills that I had learned through our group's participation with the School-Based Health Alliance. And if you're not familiar with this, that is the Collaborative Improvement and Innovation Network, which I cannot recommend enough. This was an initiative that allowed our team to refine our strategies around improving our quality of care and using best practices to promote sustainability, and really provided a framework through which we can practice process improvement, and all of that can occur going forward. If you have an opportunity to engage with this, I would really encourage you to do so. It just gives you a great little set of tools to use for the rest of your career. It's very powerful. So we can go to the next slide. Very briefly, this was my project aim, so kind of like my goal for the pilot phase of these interventions, where we just started looking at intimate partner violence in the school-based healthcare setting. So I wanted to increase intimate partner violence screening among adolescents age 12 and up, presenting for a well check in a school-based health center population from 0% to 50% by May 2020, and sustain for at least 1 year. So there are already several actual experts on teen dating violence, intimate partner violence, and youth violence on this call today. So you don't need me to share too many facts about that subject. However, I am going to talk very briefly about what IPV can look like in the primary care setting, because IPV can be very easy to overlook, friends. And if we are overlooking it or not considering it in our differential diagnosis list, then we are also missing out on our chance to intervene, our chance to counsel, and ultimately our chance to prevent, right? And here you can see a list of long-term effects of intimate partner violence, which are pretty significant in and of themselves, right? But also what you're going to notice is that a lot of these are reasons that a young person might visit your SBHC, right? The differential diagnoses you think of when you see kids for these complaints often can and should include intimate partner violence, because truly, this violence does not occur in a vacuum. And awareness and prevention of this particular problem can help to prevent significant complications and adverse events for youth throughout their lifespan. We can go to the next slide. Very briefly, if you remember our pilot phase, we had a very specific aim of implementing universal assessment of IPV along with changing the culture of our clinic setting in order to better facilitate conversations about healthy relationships with our youth. We had a specific time frame for that, which COVID adjusted for us a little bit. Despite that, in an abbreviated comparison period, we were able to identify several kids in a 3-month time span who were survivors of IPV and connect them with services they might not have otherwise had. Disclosure is not necessarily the goal in this process. It happens, but the goal ultimately really is to connect these kiddos with support and services on their terms. And I was very pleased that we were able to do that in such a brief time span. And we've been able to kind of further refine that algorithm going forward based on the knowledge we gathered in that pilot phase. You can go to the next slide. Since we knew that this work was feasible or possible with our team and in our environment, we then had to repeatedly speak to our stakeholders and evaluate our successes and our opportunities, right? We know that marginalized and sexual minority youth are at increased risk of partner violence. And it was important to have a process that both inclusively addressed these kiddos and provided resources internally and in the community for survivors. We also realized after gathering experiences from our team that we were missing huge opportunities to ask our patients about digital dating violence, digital dating aggression, and monitoring behaviors in their relationships. And given how those factor into the pathway of commercial sexual exploitation of children, we needed to incorporate that as well. And like yesterday, right? And here was another area where I realized my failures, for lack of a better term. I was once again not addressing youth in need by not assessing for DDV, DDA, and monitoring. So was I doing zero preventable harm? No, I needed to do better, but I wouldn't have recognized that if I was not constantly looking at feedback from my stakeholders. Also critical was recognizing the weight of additional tasks that we were asking our staff to do. I don't know about you guys, but our school-based health centers are minimally staffed. We have a provider, and then we have either an MA or an LPN. So, and each of those roles probably fulfills an additional 5 jobs at the same time. Any additional work that we ask people to take on must be heavily considered before we actually mainstream it. So when we have to consider the mental burden of additional task work. So whenever it's possible, we try to move things to the system level by utilizing things like our electronic medical record, whenever possible, putting in health maintenance alerts, things like that. Anything that we can do to kind of operationalize this work, we were doing whenever possible. And that was helpful to our team. So we can go to the next slide. Okay. I'm sure this is maybe not the content you thought you were getting when you signed up, but surprise. Much like other campaigns in pediatrics, we've kind of decorated the space with visual cues of, what is serving our aim. In this case, it's visual cues of healthy relationship boundaries, reminders that our clinic is a safe space, and empowering messages for our young people. And actually, this then allows them to start kind of having conversations about, when they so feel moved, or speak with each other about various posters and signs. And our patients actually really have taken to this initiative. They bring in posters, and then they bring in artwork that they've done that, kind of talks about safe relationships and healthy boundaries. And this has all been really critical for them having ownership over this space. And then that in turn allows them to provide a healthy reference point for each other and for the environment, which has been really great because we know that they're going to go to their peers first for counsel before coming to an adult. We know that. And then that also just kind of, that gives them a sense of youth friendliness and ownership in the clinic space. And that's been really important for us as well, because they've provided us some really valuable feedback. And I want them to do that. This is their space, you know? I mean, they've provided feedback on the entire process. Like I had a kiddo tell me 2 weeks ago, like, oh, it's really good you guys asked those questions. That really gave us something to think about. Or like, you know, oh, I like the new poster. I like, you know, and they talk about it amongst each other, and then they come and give me feedback all the time. Sometimes about things like my clothes, which I didn't even ask about, but it's fine. It's feedback and I will take it. You can go to the next slide. So actually, again, probably didn't think it'd be seeing a picture of a bathroom, but joke's on you. We are very big fans of resources in our clinic settings, and amongst those resources are these little cards that we have everywhere. So we have them on the walls, we have them in the hallway, we also have them in our bathrooms, and the cards have resources for kids and adults who find themselves in violent situations. The cards themselves have contact info for local agencies, emergency services, etc., and they're available in English and Spanish and Somali. That's right, you know, posted next to the paper towel dispenser. And the one we have in the bathroom is there specifically because it's a more private setting. You know, you can go in and discreetly take a card if you need to. You need to do that without someone noticing. That's fine. We also monitor how frequently they're taken and kind of just keep tabs on that. And if, you know, one language is taken more frequently than another, it's just something we monitor a little bit. But we just make sure, you know, certainly, again, I've taken notes from the experts on this panel who talk a lot about making sure that there are resources available at all times. And this is one of the ones that we keep tabs on. Go to the next slide. This is very briefly a digital rights poster that kind of serves to help kids remember that they do have rights to not be monitored online. This is one that we've adapted from loveisrespect.org. It's just another visual cue that, you know, you are your own person and you deserve to be safe. You can go to the next slide. This is we have a few community agency partners that work specifically in IPV. I have a goal to further strengthen those relationships. We're slowly starting to collaborate with other hospital departments and community pediatricians to encourage this work. And as I mentioned briefly earlier, we are broadening our school-based healthy relationships and healthy boundary education with our middle schoolers in our district. And we're big believers in regular feedback. And we report out frequently with our team, you know, how's this going? How are you feeling? But we also do a lot of data sharing, right? We do epic data pools all the time and check on our, you know, our compliance and, you know, our assessment data. And then we share that data with our partners and say, like, you know, we're really doing a great job getting this done. And, but again, what is your take on the process? You can go to the next slide. You know, I think certainly whenever you're trying something new, it's sometimes hard to get everyone on board. And I think anything involving tough topics with kids is going to be even harder to launch. So it doesn't surprise, I'm sure it won't surprise anyone that there have been some barriers here. It's hard to help people feel empowered to tackle tough topics. But, you know, I think when you take a topic that's already difficult and you add in the challenges such as like adolescent confidentiality limitations, working with maybe a criminal justice system that doesn't necessarily always support survivors, especially, you know, women and children, I think it can be even more difficult. What I would just say has benefited us is going one day at a time, and again, going to the QI principles to really work with change wherever you can find a process to improve. That's what I would encourage people to do. I know I'm running out of time, so I'm just going to go a little bit faster. I think, you know, as far as our project is constantly evolving, we are constantly looking at ways to improve care for our patients who, like yours, are already marginalized and already quite vulnerable. An area of concentration for us currently that we're really trying to refine our practices around is continuing our CSEC initiatives, the commercial sexual exploitation of children, and refining our clinical tools there. The Venn diagram for kids at risk for human trafficking and also survivors of IPV has a lot of overlap. Plus, Ohio is a hotbed of human trafficking activity, so we're really focusing on this area a lot at the moment. We have a lot of PDSAs, planned use study act cycles, in motion, if you know, around this topic. So we're hopeful that we can continue to refine our practices and draw on the expertise of local and national experts to make kids in our area as safe as possible. So thank you so much for your time.
Wonderful. Meg, you're like my new best friend. It's so great. And Nationwide Children's Hospital is really one of the leaders in adolescent health across the country. And what you're seeing is why, right? And super focused on culture change. And so I'm going to take us to the end and then hopefully to some discussion as well. But really thinking about, and Meg alluded to this as well, which is that we have some really significant barriers to addressing adolescent relationship abuse. For those of us who are health professionals, it sometimes feel like we don't quite know, is this part of our scope? We're uncomfortable, don't have enough time, and in particular serving minors. What about child abuse reporting requirements and so on and so forth. And so just in the interest of time, just want you all to focus on what you think some of those barriers might be. In the next slide, the patient-centered approach to adolescent relationship abuse, and Meg was really underscoring this, is that patients want us, right, to talk to them about their relationships. They have concerns about how any information will be used, right? So they want to make sure that we're documenting things confidentially. And we have the opportunity to shift the power dynamics to empower patients with information regardless of disclosure. And this is such an important part of what Meg was just saying as well, because the perfect screening question is not going to necessarily increase disclosure, or put another way, there's no single right question. Next slide. And, what if disclosure and case identification is no longer our goal? What if, as Meg was underscoring for us, that we think about the health setting as creating a safe and supportive environment for young people, and that as health professionals, we are there to create relationships with young people. And we know that screening is just not great. The disclosure rates are super low. They're not actually what survivors want us to do. And a patient has to say yes to a screening question in order to get referred, in order to get resources. So the many of our patients who would say no, including the story that Meg shared with us as well, is that the resources are only offered based on a patient's disclosure, and thus we miss an opportunity for prevention education. Next slide. So want to, and I'm going to keep this going, but want you all to think about, right, in the chat, why might a young person choose not to talk about their experiences of being in the sex trade? Meg just talked about CSEC, the commercial sexual exploitation of children, or experiences of violence and trauma during a health visit. So, think about all of the reasons that our young people may choose not to disclose to us. Next slide. And certainly I'm seeing, all of the in the chat here, right? Judgment and stigma. And as you're putting ideas in the chat, make sure you're sending it to everyone so they can see, but fear, shame, stigma, if there's someone controlling or exploiting you, fear that that person could find out, what those consequences might be, and not being aware of one's rights. So next slide. We all get that, right? And so what happens then if we shift, right, to creating a safe place, right? It's about building trust and promoting safety, provide, private place to talk with students alone, displaying highly visible educational posters on consent, as you were just hearing from Meg, having information about hotlines, safety cards in common areas as well as in the bathroom, and having intake forms that acknowledge intimate partner violence and sexual violence. Next slide. The paradigm shift here then is really pushing us even beyond trauma-informed care. And I don't have a lot of time to go into this today, but want to plant the seed with you all that, we've gone from what is wrong with you to what happened to you, the what happened to you being trauma-informed care. And I want to encourage us to think about, asking our patients, where do you want to go and how may I help you get there? Which is a much more healing-centered and frankly, young person-centered approach that I think many of us as school-based health center practitioners, adolescent practitioners totally do already, right? Healing happens in relationships. We're promoting trust and connection. It's asset-driven. It focuses on a young person's agency and their control of their well-being. And it is explicitly political rather than clinical, because what we're thinking about with healing-centered engagement, and this is quoting, Sean Ginwright's phenomenal work in this space, is involving culture, spirituality, civic action, and collective healing, recognizing that there are multiple reasons, in particular for our young people who are experiencing marginalization, for whom a disclosure-driven practice does not feel equitable, certainly does not feel safe. Next slide. So the intervention that I am going to share with you very briefly, and then just to say this is indeed an evidence-based intervention, is called CUES. C for confidentiality, U for universal education, E for empowerment, and S for support. And I'm going to include in the S there support and safety. So next slide. An example of this, of course, is confidentiality, that we do this so routinely in our care with young people. Your story is your own. I don't want you to feel like you have to share anything to get support. And if I have a young person who tells me, X, Y, or Z, I do have to get others involved to help that young person be safer. So we always disclose the limits of confidentiality. Next slide. And then universal education, it takes 10 seconds or less. Many of the young people I take care of have been put in situations where they don't feel safe in their relationships or where adults have taken advantage of them. If this is part of your experience, I want to make sure you have support should you ever need it. This is just an example of offering the universal education. Next slide. The safety cards, which I'm going to talk about in a moment, I've started giving 2 of these cards to all of my patients in case you're ever struggling in a relationship or if you feel like someone's taking advantage of you. So you have the information to help a friend or family member. Next slide. So that last part about sharing with a friend or family member actually was one that in the as we were creating this intervention and working with survivors, working with practitioners around developing a brief clinic-based intervention, the adding in case this is, if it's not happening to you, please take this information in case you can help somebody else, actually occurred in a clinic with a young person who was like, oh, that's not happening to me right now. And the very savvy clinician was like, well, maybe you know somebody who could use this information. And the young person paused and goes, can I have 3 of those cards? And so that's what we're doing here. And you totally get that this is positive youth development, right? It's tapping into the altruism. I'm sharing this information with all young people because I think it's so important for young people to know how to help each other. Another example of this is I need your help with getting the information about these super helpful crisis lines to other young people. And while in a moment, I'm going to introduce you to the safety card, there are some instances where, in particular, because I take care of young people who are unstably housed, for whom carrying around a palm-sized safety card is just not practical. And I will actually have the young person put my name into their phone and all the crisis hotlines. And so, Liz is in a lot of young people's phones in Pittsburgh with all our hotline numbers. Next slide. So while there is certainly, I'm telling you, and you've heard from Meg, disclosure is not the goal. Interestingly, when you take an approach of like, your story's your own, I'm sharing this information with you just in case, you can help somebody else with it. Inevitably, I have a young person who leans in saying, I feel like I could tell you everything. Right? Because part of what we're doing is building rapport, we're building trust, we're building relationships, and disclosures do happen. Next slide. And when they do, for me, I think about this as one of the most incredible gifts from a young person. When they have chosen to share a story with me, I do thank them and thank them for trusting me with their story. And I hear you saying that things are complicated. And would you like me to offer some thoughts on what other young people have found helpful? Asking for permission to provide the resources. Next slide. In addition, and I said earlier, the S is for support, but also for safety, is that as practitioners, we cannot forget that there are also harm reduction strategies that we can offer, and in particular around reproductive health, right? The opportunity to offer contraception that a partner doesn't have to know about, giving extra doses of emergency contraception. Did this actually just yesterday with one of my patients, helping them notify a partner anonymously about a sexually transmitted infection, or supporting a young person who is choosing not to notify a partner about an infection and how to navigate that. Next slide. The S is also promoting the health of students who are survivors, right? And so when a young person does choose to share their story, doing things like, would you like to use the phone in my office so it doesn't show up on your cell phone? Would you like me to help? And I can pretend to be the health department to call the person you're having sex with to tell them that they need to get treated for an infection, and so on and so forth. We can be really creative about how we work with young people to support their safety. Next slide. And certainly reducing harm when we do have to involve Child Protective Services. Remember how we talked about situations where a young person's being harmed? This is one of those situations. And I do need to involve people to help keep you safe. Would you be willing to make the call with me? Doing what I call client-centered reporting. Every call I make to Child Protective Services, I do together with the young person in the room because it's their story. And I find that incredibly important to do. Next slide. So in terms of supporting a patient, when we do need to make a report, what I want to share is, including the patient in every step of the reporting process. We know that our Child Protective Services, our reporting requirements are clunky and our systems are imperfect, but certainly not forcing our patient to provide information or details they're not ready to share, that they don't feel safe sharing. And providing the safety card, the educational safety card that is designed for young people by young people, offering to let them use the office phone, and then certainly arranging follow-up visits. We're very, very fortunate here in Pittsburgh to have a victim service advocate who sits in our clinic once a week. And we are in our clinics then able to set up follow-up appointments where I'm like, it's a birth control follow-up appointment, but it in fact is for the young person to meet with the advocate. And I see a comment in the chat saying, right, the teen dating abuse does not require child abuse reporting in our Commonwealth of Pennsylvania. And so more often than not, it is really finding confidential ways to connect young people to victim service advocates. Next slide. So national support lines. And so the kinds of information that we want to make sure are readily available for young people. And for those of you who've not called these support lines before, they're super accustomed at this point of having health professionals call saying, I just wanted to check out what it was like to reach out to you so that I can talk to my patients about this. And I strongly recommend that you do that. And next slide. I did tell you that this, approach, the CUES approach, is an evidence-based approach, and we actually have evaluated this in school-based health centers as well. The evaluation component included distributing a healthy relationships card with every clinic visit, offering some more direct assessment during sexual health related visits, specifically around sexual and reproductive coercion. And then because it's school-based health centers, right, we encouraged the youth advisories to lead relationship abuse awareness in the school as well. So this was funded by the National Institute of Justice. Next slide. What we found was that the results increased recognition of what constitutes sexual coercion. So young people were more aware, but they were also more aware of relationship abuse resources, right? So super helpful. And then really, truly not expected because this was not a disclosure-based intervention. We really didn't talk about leaving relationships. It was really intended as a supportive and safe intervention. But we actually found less relationship abuse victimization at 3 months follow-up. And even though it's not a disclosure-driven practice, increased likelihood of disclosing any history of an unhealthy relationship to the provider. And we have now evaluated this approach in college health and counseling centers, in women's health clinics and family planning clinics, demonstrating pretty similar outcomes as well. And so, the work that we do with within our school-based health centers is profound, right? We have an incredible opportunity to do prevention education combined with a clinic-based intervention. And providers do not have to be relationship abuse experts to recognize and help our patients experiencing violence. if there is one bit of homework, well, I gave you one bit of homework, which was calling the hotline numbers, but the other piece of homework is if you don't know well who your victim service advocates are, if you don't have them on speed dial, please work on that. Set up memorandums of understanding. Some of the work that we do in the national training is also, helping set up these memorandums of understanding, and would really encourage all of us to do this. And next slide. So rethinking the way in which we define our success, right? What happens if instead of case identification, we think about success as measured by our efforts to reduce a young person's sense of isolation and to improve their options for safety? Next slide. So the safety cards that I have been referring to, please check out ipvhealthpartners.org. I've had the incredible privilege of working with Futures Without Violence for a number of years as a consultant, really helping to be the evaluator of this work. And it brings me so much joy to have work that you can then, just readily accessible, it's free, and we are there to help with the implementation. I think I've left some time for questions.
Thank you so much, Lisa, Meg, and Dr. Miller, for all your great content. That was really wonderful. Now I invite everyone to enter your questions into the Q&A. It should be in your Zoom control bar, and then I will pass it over to Emily to moderate.
Thank you so much, Maddie, and I would echo that. Thank you so much, Dr. Miller and Meg and Lisa. This has been really wonderful for me. I'm so glad that you all could be with us today. There were a couple of questions that came through during the session that Lisa very generously answered by typing, but they're important, so I'd like to sort of bring them up again here. Someone asked about plans for working directly along domestic and intimate partner abuse programs and agencies to holistically address this concern. So I know, Lisa, that you just shared in the chat box some guidance around MOUs, but wondering if anyone would like to chime in about some additional strategies for building and maintaining those relationships.
Yeah, thank you so much. I'll just jump in and say thank you for the question and comment, because it's absolutely critical, as Liz just talked about, to reach out and understand what are your local programs, what services do they offer, what happens if you make a referral, so that you are familiar and it's not just handing a form, basically, but that how might the young person get there, what languages are spoken, really understand the type of services that are provided. Are they youth specific? So definitely reaching out is critical, and then building meaningful partnerships can look a lot of different ways, but really working together to think about how will referrals be accepted, and how might you communicate around what's happening and how those referrals were handled. So we've seen so many beautiful partnerships where, when that kind of meaningful connection is in place, there is some cross-learning, opportunities for cross-training, and even opportunities for health providers to go to the local program and offer services. So lots of great models on that website that I included into the link around partnerships and particularly MOUs.
Thank you, Lisa. And I will say that many years ago, I worked at a domestic violence program, and it would have been my dream for a school-based health center provider to give me a call and say, let's work together on serving students. So speaking from the other end of it, I think folks would be thrilled to receive those calls. Someone shared that we need to be careful about putting explicit hotline names into cell phones, and I think Dr. Miller alluded to that, but just want to sort of bring that up again for the whole group. So using the name Liz or putting it in as the name of the grocery store Lisa suggested. I think that's great. Someone asked about if teen dating violence does not fall under mandated reporting guidelines in your state, are there still cases when it would be advised to report?
So I can jump in here and just note that Since this is national, every state has different rules and different laws. And in fact, every community and county implements those differently. You can feel free to reach out. I'll put my email into the chat, and Futures has a review of state-by-state review of those reporting laws. And then definitely understanding how they get implemented in your county, and what, again, just understanding what happens if you have to make a report. And we didn't have time to go into too much depth about it, but how to make a trauma-informed report and supportive report when you do have to do that reporting. And Meg and Liz, you might have more to add there.
I would just actually, I mean, I think you covered it, Lisa. I would just say that I think there have been times when, if it doesn't meet reporting guidelines, I've seen people still attempt to report to local agencies, and the local agencies won't take the report. So there's that. But then also, I think I have also seen reporting through maybe the school to try to get more protection at a school. Often people date people at school. So I think that there's some validity to that too, because if you're having trouble getting, keeping a child safe at school, if the abuser is there, there's a reporting pathway that some schools have through the school district that can maybe be more productive depending on their bullying policy or what policies they have in place. I don't know if that exactly is helpful, but I have seen more productivity there. And I would also certainly add that all of that is done with the survivor's consent and in process with what they want.
Thank you, Meg. Another question that came through is about teens who are quiet, spending time alone, doesn't want to talk. My guess would be that could be a number of things, but want to open that to our panelists to give some feedback about how they might approach that situation.
I think that's a super common reason to refer. I mean, we see a lot of kids for maybe behavior changes or low mood. And I think if, someone is noticing that there's an acute change in a child's presentation, then I think having them evaluated and looking at, maybe physical as well as other mental, emotional contributors to that is really valid. And there's a number of things that anyone would do to work that up.
Indeed. And I think, what Meg was saying earlier is having this on our radar all the time, I think is really the key, right? Recognizing that young people who are in abusive relationships, because of all the health consequences that we talked about, are much more likely to be showing up in our clinics with abdominal pain, with headaches, difficulty sleeping, and the like. And I just want to share with you a story of a young person who came in with abdominal pain, who had seen gastroenterology 3 times, OBGYN 3 times, and then finally they were like, go see adolescent medicine. And one of our spectacular nurse practitioner students, like within 3 minutes, came out with the story because she was just doing universal education. And she's like, yeah, this young person hasn't left her room because her boyfriend is constantly checking up on her and making sure that she's like online in front of her computer and not going anywhere else. And it was really one of these remarkable, being able to get permission from the young person to get help from her mom and be able to then connect them with a victim service advocate by phone while they were in clinic with us that day. And so again, just being able to open up the conversation, this young person was just so ready to share what she was experiencing.
That's wonderful. Thank you, Dr. Miller. Thank you for those questions. Thank you for attending and participating in our chat. In addition to being so thrilled about our panelists, I'm so glad that all of you attending were able to join us as well. I'd like to invite you to complete our poll questions. They are very useful for us in terms of evaluating our content and the presentation of that content. So we invite you to take a moment to complete those, and then you're welcome to sign off, but certainly follow up if you have questions or additional feedback. We would love to hear from you. Thank you so much.
Thank you.
Thank you.